ترجع السعودية ولا بس هيك عن بعد تكون؟
عن بعد.
عن بعد.
عن بعد كيف؟
ترجع السعودية ولا بس هيك عن بعد تكون؟
لا. عن بعد بدي، يعني مش سفر.
ايه ايه.
اه.
الله ييسر لك.
يعني بس بدي اسافر بعد سنتين، بدي اقدم إلكتيف يا اما بجامعة هارفارد يا بستانفورد. بدي اقدم على منحة. يعني
ان شاء الله.
هم بيعطوا منح إلكتيف لطلاب اللي بالسنة الأخيرة.
أمم.
آه، فأنا بدي أقدم على واحدة منهم.
أمم. منحة مشان شو تكمل ماسترز ولا مشان شو تحديد؟
لا، منحة يا الإلكتيف.
نايس نايس ما شاء الله الله ييسر.
آه.
نايس والله. مين البريزيدنت تبع البان عرب this year؟ ما عندي فكرة صراحة ما طلعت عليه أنا.
البريزنت هو صلاح العكاد.
اوه نايس.
عرفتيه؟
ايه
هذا
عرفت.
هو.
ما
هذا
شاء
هو.
الله. نايس. بأي شهر رح يكون؟
بشهر واحد.
شهر واحد.
شهر
اوف.
واحد.
مؤتمرات النيورو سيرجري عنا بشهر واحد. عنا السعودي Association of Neurological Surgery Conference كمان بشهر واحد.
آه.
شهر واحد is gonna be busy.
مم.
يلا إن شاء الله الله ييسر.
آه. عندكم في دكتور اسمه محمد السبيع، بتعرفيه؟
طبعا.
آه. صديقي هذا.
أوه نايس، كيف تعرفت على بعض؟
على الفيس تعرفت عليه.
حلو ما شاء الله. أنت لاحظت إنه كل صداقاتك على الفيس، أنا يعني أكتب
آه.
على الفيسبوك أنت ما شاء الله.
يعني شو قال؟ هذا على الفيسبوك أنا.
نايس
Bob,
نايس.
my video is no longer working
Hold on, we'll check it. Hold on, give me a second.
because when I'm putting video, it's saying it's disabled by the host.
Okay.
دكتور عاطف.
Can you still see my slides? Maybe you can't see me, but can you see my slides?
Yeah, we can see your slides.
يس.
Okay. Yeah, for some reason the video is not working.
Yeah, hold on. Okay, I want to take Humana, I want to take you off the screen share, please. Can you go off screen share?
I'll stop sharing, no problem.
Yeah, there we go. Okay, that way you can be introduced straight to your face. So, I mean, you know what I mean, Hamad? Excuse me, Muhammad, could you put your face on the screen? Oh, okay, we're about to start. You there, Muhammad?
I'm here.
Okay, I need to put your face on
Let's,
the screen,
let's-
please.
yeah, every time I press the video, it's not working. So it's not working.
Oh, okay, let's try to work on that. Yeah, we haven't started. Okay, try to play the video. Okay, share this video now. Then
Okay, let me try again.
let's try it.
No, I don't think it's gonna work.
Yeah.
Nobody needs to see my face. We can just get started.
Yeah, share the screen and let's try the video. There's no hurry. Okay, test what you want to test. Okay, you want to test the video, right?
I think we just get started.
Okay, you want to test the video or?
It's not working.
Oh, really?
Yeah.
Okay, well, can you attempt to use it now, please? It's not even going to the page, huh? Click to the right of the page. That'll move it forward. Click on to the right of the page. There you go.
Yeah, this is working fine. The PowerPoint is working fine. It's just the video through like to see my face, but nobody needs to see my face. They know how I look like.
Okay, well, we have to see your face. Period.
Yeah.
So do you want to work on
I think we
the
should just get
video?
started. Let's just get started. We're 3 minutes late already.
Okay. Okay. I'll beat you. I'll take you off the screen share then.
No, I'm fine. I can still screen share. Just not see my face. It's fine.
Okay. Okay. Let's start. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett broadcasting another Walter Dandy Yemen webcast. We'll start things right off. I'll introduce the moderator, BM Sado. She's a last year medical student. She'll be starting the big dive next year, and I'll let her basically direct the show. Go ahead, BM.
Thank you so much, Dr. John, for the introduction. So good evening, everyone, and good morning to those joining us from different time zones. It's a true honor to welcome you all to today's online webinar hosted by the Saudi Arabia and Yemen chapters of the Walter E. Dandy Neurosurgical Society. The title of today's session is Pushing the Limits of Minimally Invasive Spine Surgery. As Dr. John introduced me, my name is Bayam Saido. I'm a final year medical student at Al Faisal University in Saudi Arabia, and I'm also the president of the Saudi Arabia chapter of the Walter E. Dandy Neurosurgical Society. I'm here with my co-hosts, Dr. Ahmed Al-Ghanimi and Dr. Abdurrahman Al-Atar. We're privileged to be joined by two internationally renowned leaders in spine surgery, both of whom have played transformative roles in advancing minimally invasive and endoscopic techniques in this field, Prof. Mohammed Abdel Bar and Prof. Atif Malik. Prof. Mohammed Abdel Bar is a board-certified neurosurgeon and a global leader in endoscopic and minimally invasive spine surgery. He currently serves as the Chief of Endoscopic Spine Surgery and the Vice Chair for International Affairs in the Department of Neurosurgery at Duke University Health System. Prof. Abdel Bar earned his Bachelor's of Applied Science in Bioengineering and Biomedical Engineering from the University of Toronto in 2000. He completed a Master of Science at the University of Texas at Austin in 2002, then pursued both his MD and PhD in neuroscience at Baylor College of Medicine. He began his neurosurgical residency in 2012 at Brigham and Women's Hospital and Boston Children's Hospital, Harvard Medical School, and completed it in 2016. He later completed his spine surgery fellowship at Brigham and Women's Hospital, specializing in complex and minimally invasive procedures. Prof. Abdel Bar currently serves as the Chair of Innovation and Technology Committee at the World Federation of Neurosurgical Societies. He has published numerous peer-reviewed articles and book chapters in the fields of spine and neurosurgery. Our second speaker is Prof. Atif Malik, who is a board-certified interventional spine specialist with extensive experience in minimally invasive and endoscopic spine surgery. He is currently the Chief of Endoscopic Spine Surgery at the Orthopedic Institute of New Jersey in the United States of America. He earned his Bachelor of Science with cum laude honors in Fine Arts, Biology, and Chemistry from Houston Baptist University and completed his medical degree at St. George's University School of Medicine. Prof. Malik then completed his residency in Physical Medicine and Rehabilitation at Baylor's College of Medicine, where he served as a chief resident. He then pursued a fellowship in interventional pain management at Harvard Medical School Beth Israel Deaconess Medical Center, followed by further specialization in percutaneous and endoscopic spine surgery under Prof. Thomas Hoagland at the Alpha Clinic in Munich, Germany, and the Waridel Hospital in Seoul, South Korea. Prof. Malik is the founding innovator of Spine Pulse and is widely recognized for pioneering minimally invasive endoscopic techniques that preserve health disc tissue. He also contributed to the development of intradiscal stem cell therapy, PRP, and advanced laser and radiofrequency techniques. He has published extensively in the fields of pain and spine medicine. So if you have any questions throughout the session, please feel free to share them in the chat box or in the questions tab that you can see. We will make sure and try our best to address them in the Q&A segment of this session. So without any further delay, let's officially welcome Prof. Abdelbar with the presentation. The floor is yours, Prof.
Thank you so much, Dr. Biam, for the wonderful introduction. That means I'm a very old man with all the training, but we'll see what we can do. Today, I'll be talking about pushing the limits of minimally invasive spine surgery. And thank you for the invitation again. Here are my disclosures. So before we start, we want to talk about the motivation behind minimally invasive spine surgery. Why are we trying to do minimally invasive spine surgery? And then we'll talk about important adjuncts, perioperative care, radiation reduction, robotics, and some work that we're doing on nerve segmentation. So when we look at defining minimally invasive spine surgery, we want to define it as surgical techniques that minimize the trauma to overlying tissues, but we still have to do the surgery. So the incision is not the important thing, but what we do with the overlying tissues is what's important. If we look at Hippocrates, he says that when you have two choices, you should choose the one that's least troublesome to the patient. So in some ways, he was a minimally invasive spine surgeon. We'll start off with a case. So 87-year-old with mechanical back pain and bilateral leg pain. He's got, a lot of comorbidities, congestive heart failure. He's tried injections. He's tried physical therapy. He even had a quote unquote laser spine surgery in Tampa. And you can see here, he's got a little bit of scoliosis. He's got, if you look closely, a mobile spondylolisthesis at L4, L5. If you look at his MRI, he also has stenosis at L2-3, stenosis at L3-4, and a little bit at L4-5. So, I think a very pertinent question is, should this patient even get surgery? As one of my former partners used to say, the only elective surgery is the first one. And so, they come to you with these cat eyes and they're begging you for surgery. And who do you decide who you're going to do surgery on? Can we do more than just, rely on our gut feeling with whether a patient will do better, whether with surgery or not? I think we can. And so we started to look at this using actually some machine learning and so on. So we published this paper recently in the Spine Journal, looking at the use of machine learning to diagnose and to treat patients. So this is, it's not surprising to see over the years, there's been an explosion in kind of the interest in using machine learning. And most of it is looking at detection of low back pain. We also look at the fact that more and more people are looking not just at MRI, but other things other than the MRI as well. And if we look at the patient with low back pain, unfortunately, their kind of way of trajectory is almost like a zoo, right? Depending on where they go, depends on where they're going to end up. So if they go see a surgeon, there's a lot of chances that they're going to have surgery. If they go to physical therapy, they may get physical therapy, they may get some opioids, they may get something else. And this really shouldn't be the case for any medical condition. So what we'd really like to do is, can we use machine learning to determine where the patient should go and not have so much subjectivity in how the patients go. So how do we define success? If we look at just patient-reported outcomes, that can be limited, because if Mrs. Jones comes to my office and I give her 200 milligrams of oxycodone, but she has a grade 2 spondy, her patient-reported outcome might be very high, but that's not the best thing for that patient. So what we looked at is in terms of healthcare utilization. One of the ways that we looked at is looking at use of opioid use. And so far, our models are doing just a little bit better than chance. But as we get better and better, I think that we're going to perform even better in deciding and predicting who's going to be using opioids at 90 days, 180 days, and a year out. So what we'd really like to have is from this kind of zoo way to a much more streamlined way. And this should be the case for any medical condition. Now, we need to realize that surgery is traumatic for the patients and their loved ones. And as surgeons, we really need to decrease the surgical footprint. I was invited to give this talk a couple of years ago about ERAS. And if you look at ERAS, it's enhanced recovery after surgery. And I really think that we should change our mindset and it should be with surgery. And so we really need to look at four phases of care. We look at the preoperative care, intraoperative measures, acute postoperative, and chronic postoperative care. If we look at the preoperative optimization, we've looked at this quite extensively, and we were able to look at 8 modifiable factors that can help you be successful with surgery, measuring people's blood sugars and regulating that, their blood pressure, their smoking status, their renal function, their nutrition, their BMI, their psychosocial factors, as well as their bone density. And so now actually, when I see a patient in clinic, and I think that this patient may be a reasonable surgical candidate, we have this kind of smart phrase, and we ask them these pertinent questions. And anything that kind of lights up as a yes will then be lit up as a red flag. Say, hey, before you schedule surgery, let's make sure that we've optimized this patient. We also have what's called an indications conference, where every week we show different cases and we have a kind of a multidisciplinary way to look at these patients. Now that we've finally decided that a patient may be appropriate for surgery, we also have to realize that anesthesia can be just as important as surgery. You know, when we look at our surgical footprint, we look at surgery, but we also need to realize that anesthesia is an important footprint to what we do for these patients. So that's why at Duke, I have a great collaboration with our anesthesiologists. And we've really made a way where surgery is just part of the day. So we have a whole kind of workflow. Patients come in, they get preemptive analgesia, they get some type of block. Then if they're a candidate for a spinal anesthesia, they'll do that. And then we have a post-op management way. We've really, and I think that the orthopedic people probably are better at this, but looking at regional anesthesia, so looking at different blocks for different types of surgeries, and we have some preliminary evidence that show that these blocks actually make a difference. Now, in terms of planning, you know, I think that the spinal pelvic parameters is something that's really, really important, but I think what we can do much, much more. So actually what we're doing is using the MRI to really segment out the bones, the nerves, all the other structures in the spine before we even cut the patient. We can look at each level. We can look at how big Camden's triangle is. We can find out whether there's a conjoined nerve root. And so really our planning is now going to the next stage. So we also looked at fusion surgery, and we broke it down into different kind of small steps: placing pedicle screws, interbody fusion, and decompression. So looking at placing pedicle screws, the way I was taught was an open technique. You do a midline dissection, you do a subperiosteal dissection, and then you find the starting point for your pedicle screws. But this is kind of counterintuitive. Why would you go from medial to lateral and then go from lateral to medial? And so instead of doing that, why don't we make what we call paramedian incisions and go straight to the pedicle? Now, to do that, you're going to have to rely on fluoroscopy. And we know that minimally invasive surgery is really good, but one of the bad things is that the fluoroscopy time can be sometimes 3 or 4 times more. And we have to realize that fluoroscopy and any type of ionizing radiation is dangerous. It's dangerous to us as physicians, and it's dangerous for our patients as well. And so what we've done actually is we've developed this, what we call a computer assistant instrument navigation system, where the fiducials, instead of being on the patient, is actually on the C-arm. And then we have a marker that we put on any instrument, and then we use infrared markers to be able to do it. So this is fluoroscopy-based navigation. It allows you to see where you are and where you're going to be, both in the lateral and the AP dimensions. And it allows us to, unlike other navigation systems, we can actually put in 2 screws at one time. So it decreases the amount of time considerably. So we published on this looking at pedicle screw placement. We showed that we can decrease the radiation by 70%. We go faster by 63%. We also showed that our variance is much lower. So sometimes, it's very easy to find the starting point for a pedicle screw, but sometimes it's very difficult. And so every time you move, you have to take another X-ray. But with our system, you don't have to take an X-ray. So the amount of radiation is much more conserved. We also look at the accuracy. It's not just important to be fast, but you have to be accurate. So we actually compared it to my robotic cases, and we found that the accuracy is about the same as well. Now, in terms of interbody fusion, we're going to mostly look at T-lifts for today. There really are three different flavors. There's the MIS T-lift, which is basically an open T-lift through a tube. Then you can look at what's called the transfacet T-lift, which is kind of docking on the facet joint. And you can do the percutaneous one through Camden's triangle. And so we've been very interested in Camden's triangle in the lab. We looked at a systematic review looking at cadaveric samples. We showed that as you go caudal in the spine, Camden's triangle increases. And if you do a foraminoplasty and you take off the part of the SAP, you can actually double the area of Camden's triangle. Now, importantly, as physicians and as surgeons, we don't deal with anatomy, we deal with pathology. And importantly, when you have a pathology like a spondylolisthesis or a disc herniation, actually Camden's triangle gets smaller. So that's something that you have to be careful about. So in terms of doing a percutaneous T-lift, what we do is do our 2 perimedian incisions for the screws and then 1 stab incision to enter into Camden's triangle. The way I used to do it is using 2 C-arms. Used to take a lot of time to set up and so on. But then when we started to use this instrument navigation, we actually were able to show that we could use only 1 C-arm, have no setup time, and we actually can get faster into Camden's triangle than when we had the 2 C-arms. So this is a case, this is a grade 2 spondy, bone on bone. We put in the screws, and then this is really, really difficult to get into, but here we can show how we make it actually not that difficult. So we take 1 AP X-ray to learn our instrument. We take 1 lateral X-ray to learn our instrument. And then we basically is like playing video games. And we try to enter into Camden's triangle. I can see where I am both in the lateral and the AP. There's another X-ray just to make sure our instrument is kind of needle nose, so allows us to get into these very difficult areas. And you can see now that's 4 X-rays. That's 5. I didn't edit this at all. That's 6. But you can see we're already opening up the space. And now we've actually totally opened it up. Take 1 more. And there you go, we can open it up. And so actually this very difficult case can be done in less than an hour, actually. We've actually used the robot for a lot of other things as well, including getting into Camden's triangle. So we put in the screws and then we kind of hijack the software to enter into Camden's triangle. You can see here the robot is allowing us to enter into Camden's triangle. So this is a case we did. A patient was done awake, actually, and this took 2 hours and almost no blood loss. We've published on this case series of these Camden's triangle with the robot. I think 40% of them were done awake, and most of these patients go home within a day or 2. Now, how about the nerves? So the work that we had done earlier had kind of avoided the nerves or ignored the nerves, but the nerves are really important. So we actually use the cranial software to start looking at the nerves. So this is us mapping out the nerves even before surgery. And that way we can actually measure Camden's triangle, taking the nerve into consideration. We can also know if there's a conjoined nerve root before we do surgery. Not surprisingly, we saw that if we take the nerve into consideration, the Camden's triangle gets smaller. And then we're moving into the augmented reality, and I'll show you our current implementation of augmented reality. So here's a case, a person with a grade 2 level spondy, L4-5, L5-S1. What we did for her is we did an erector spinae block. We did spinal anesthesia. They're listening to their music. We put in the pedicle screws the way I showed you. Then we get a CT scan to make sure that the pedicle screws are good. Then we merge the intra-op CT to the preoperative MRI, and then we know where the nerves are. And so then we can navigate into Camden's triangle completely percutaneously. So this is us getting into the Camden's triangle, avoiding the exiting, the traversing nerve route. And so we do this case. It looks just like everybody else's case, right? But this was done completely percutaneously with the patient awake. This patient lost less than 50 cc's, and this patient went home the same day. If you can tell me, even as a fellow, which was only 8 years ago, that you could do a 2-level TLIF and have the patient go home the same day, I would have thought that was impossible, but this is a reality now. Now, as we started studying a little bit more, we found that Camden's triangle, not everybody's Camden's triangle was conducive for the percutaneous TLIF. So this is a Camden's triangle that only measured 6 millimeters. That's too small for anything. So then we started looking at different pathways to this, like this transfacet pathway where you enter on the facet joint. And so this is some of the studies that we've done. We've looked at measuring this. So we showed that the transfacet pathway is bigger. We can look at the maximum permissible cannula that can go that way. So here's another case. This is a young person with a grade 2 spondy, not a good candidate for an ALIF or an OLIF or a lateral. So we want to do this transfacet. So this is us with our preoperative segmentation. We put in the screws as we showed. Then we merge the CT scan to the MRI again. And then just like, you know, how driving a plane now, you have all these information kind of overlaid. We're kind of like Iron Man as well. Now we're actually, while we're in the operating room, we can actually overlay the nerves through the bone. So we know exactly the trajectory that we want, and we can stay safe while we do the surgery. And again, excellent post-operative results. So most of this work has been done by key medical students like the people on these calls, looking at manual segmentation. But now we're moving to hopefully using machine learning to automatically segment out these different pathways. Now, you've heard me talk a little bit about awake surgery. Why do we even want to think about doing awake surgery? It's not because the anesthesiologists are lazy. It's because we know that general anesthesia is not benign. You can have all these different complications when you put a patient to sleep. So this is a study that we showed showing that, you know, spinal anesthesia had shorter operative times. They had decreased blood loss. They had to have less hypotension, less post-operative nausea and vomiting, less time in the PACU, and a shorter length of stay. Now, most of these were decompressions, so we were very interested in fusions. And so this is a paper that we showed, which is a matched cohort study looking at different metrics. We found that 90% of the patients actually were able to go home within 24 hours if you did the patient under spinal anesthesia. We also showed that 50% of patients actually took 0 opioids after 1 and 2 level fusions, and their time to ambulation was also decreased. Now, this is apples to apples. It's not a matched cohort study, but it is sorry, it's not a randomized control study. It is a matched cohort study. But I would also argue to you that spinal anesthesia allows you to operate on some oranges as well. So it allows you to operate on patients that really are horrible surgical candidates. So we'll look at this one here. This is a 91-year-old. This is not my case. This is a 91-year-old who had a kyphoplasty done at another hospital. Their back pain got better, but because of the cement in the canal, they started to have horrible leg pain. Now, when they did the kyphoplasty, they actually put the patient to sleep and took them 5 days to extubate the patient. So now the surgeon told them, well, I can't really operate on you again because I'm really worried that you won't be extubated. You know, this is a horrible surgical candidate. So what we did for her is we did it awake, bilateral decompression, and we got her home the next day. And she's over a year out and very happy. So going back to our patient with 87 years old with 3 levels of disease, what do we do? I was really stuck, and this is a real guide to the trainees. Don't ever think that, you know, if you're a trainee, whether you're a medical student or resident or fellow, that your opinion isn't important. So I had a great fellow at this time. His name is Andrew Chen. I said, Andrew, we had this patient. What are we going to do? Should we just do the fusion one day and then bring the patient back for another surgery the next day? And Andrew actually had the great idea of saying, instead of operating what we call in series, which is what we usually do, we do one level, then another level, another level. Why don't we operate in parallel? So what we did for this patient, actually, we brought in 2 microscopes. And what we did is first we did put in the screws like we talked about. And then I, with one microscope, did the fusion at L4-5 at the same time that Andrew Chan was then doing the decompression. So we worked in parallel. I think this is one of the coolest videos. So this is me on the left doing the interbody fusion at L4-5. And simultaneously, Dr. Chan is doing the decompression. So we got excellent post-operative X-rays. This is a percutaneous surgery. So our surgery took less than 3 hours. We lost no blood. And this 87-year-old, after a 3-level surgery, was able to go home the next day. And we published about this in parallel technique, and I've used it several times since. And the best thing is, we have these papers and so on, but the best thing is that this patient, 3 months later, he sent me this picture of him riding his motorcycle. I hope he's wearing his mask, but now we're able to get this patient back to the life that he would like to enjoy. Now, I've talked about using spinal anesthesia to defray the problems with general anesthesia, but we know that in craniotomies, for example, awake surgery helps us look at eloquent cortex. As a spine surgeon, there's nothing more eloquent to me than the spinal nerves. So what we've actually sometimes done, instead of doing a spinal, just use local. So this is a patient, here's a case who had a 2-level decompression done somewhere else. He had a S1 radiculopathy. He went to everybody else and they said, well, the only solution for you is to do a fusion. But he said, I don't have back pain. Why are you going to do a fusion? So what we did for this patient is we did local only transforaminal discectomy. Here we use the same instrument navigation to enter into Kamin's triangle again very quickly. And then as I am decompressing the patient, this is me doing a foraminoplasty here. I'm opening up that SAP. Now you can see the yellow ligament. And now I'm opening it up with a kerosene. As I'm doing this work, you can see now here, he says, oh, my leg pain is better. Remember, this guy doesn't have any spinal and so on. So at first I didn't believe it, but it turned out to be true. So this person you don't even have to wait for the spinal to wear off. He has immediate resolution and he can go home within a few hours. So looking at other things that make our surgeries successful, looking at the acute postoperative care, we've really pushed so that patients mobilize very quickly. So even in the PACU, I have the physical therapist come by, walk with the patient, make sure that they're safe to go home. And we've shown that improves quality as well. In terms of chronic postoperative care, we've looked at using some of these mobile apps to help make sure that the patients do well. And we actually showed that it decreases the amount of ER visits by about 35%. So I don't want to take up all the time, so I'll start concluding here. I think the future of spine surgery is individualized care, looking at who should get spine surgery and which surgery, looking at regional anesthesia and awake spine surgery. Intraoperatively, we're using endoscopy, we're using robotics, we're using augmented reality, looking at expandable technology. Post-operative care, we've talked about these different systems. And like I tell my trainees, I think the future is now. So just to conclude, I think minimally invasive spine surgery is exciting for both the patients, the nurses, and the physicians. I think patient-specific and pathology-specific planning is extremely important. And collaborating with anesthesia, nursing, physical therapy is really important as well. And with that, I'd like to conclude. Thank you so much.
Thank you so much, Prof. Abdelbar. That was a great presentation, and we're very lucky and grateful for the opportunity to learn a lot more from you. So attendees, if you have any questions, please drop them. we can have a discussion with Prof. Abdul Bar.
Yes. What else?
So someone's asking if
What are the major complications or risk faced by spine surgeons when utilizing this technique compared to a traditional open surgery, and how can this risk be mitigated?
Yeah, that's a great question. So, I think that you have to make sure that whenever you're using technology, you're using it wisely. And you have to make sure that you have backup plans. So, for example, when I'm using the robot, I always have the X-ray there, even though the robotic company will tell you, oh, you don't need to use the X-ray. I always have the X-ray there to make what we call spot checks. Hey, does this make sense? Let's take some X-rays, once in a while to make sure what we're doing is safe. I would argue that I was lucky in that I trained as an open surgeon, so I'm very comfortable when the technology is not working to go to the quote unquote old ways. And so there is some argument that you should be good at the kind of traditional ways to make sure that if things are not going so well, you know what to do. So I'd say that the complications that usually happen is not actually due to the technology, but it's actually that the surgeons don't know the limitations of the technology, and they need to be very well aware of that.
Okay. How do you assess outcomes after undergoing a minimally invasive spine surgery compared to a traditional open surgery in terms of pain, recovery time, and how long time results?
Yeah, good question. So, I think we need to use a combination of things. So, we use patient-reported outcomes. That's one thing that's important. But as I said, patient-reported outcomes can sometimes be not the best because, the patient doesn't know necessarily what's best for them. I think it's very important to criticize yourself and always be critical of yourself. In terms of long-term outcomes, I think that's a really good question. And that's something that we need to, most of these techniques are very new. And so we have to see, whether they're going to withstand the test of time.
Okay. How do you foresee the future of minimal invasive spine surgery in the next 20 years? Is there the possibility that it might completely replace traditional open spine surgery?
Great question. I think that the future of spine surgery is more and more minimally invasive. There's no question about it. Will it completely replace open surgery? I'm not sure. I can tell you in my practice, probably 90% of the surgeries I do are minimally invasive. Only 10% of surgeries now I'm doing open traditional surgery.
Okay. My best thanks to Professor Muhammad Abdul Barrar for his exceptional presentations and insightful contributions, which greatly enhance our understanding uh, our understanding of the topic.
Just before proceeding before wrapping up the session, someone was asking Prof. Abdelbar if a CT scan was done for the patient you started by talking about.
Yeah, it's actually my practice whenever I put in screws to get a post-operative CT scan before I take the patient off the operating room table, just to mitigate any problems. And yeah, so every patient that I do a fusion for gets a CT scan before they come off the table.
Awesome, thank you.
And we work that into our awake surgeries.
Thank you, thank you. Okay, so I guess that's it. Does anyone else have any other questions?
I have a question, by the way. Sorry. Hi, Professor. First of all, I'm so grateful for being with us today, and it was really amazing and impressive lecture. So I have a question regarding the difference between, traditional open surgeries and minimally invasive. I would like just to know about the recurrence rate between both two operations, between both two techniques, and also which is better technique to do in case of grade 4 spondylolisthesis. Which is better, either minimal invasive or just traditional open surgeries?
So in terms of the recurrence, I think that if you look at what the drawbacks are, I think that we have a publication that isn't out yet, but it hopefully will come out, where we compared open decompressions to minimally invasive decompressions. The problem with open decompressions is that 5 to 10% of those patients will need fusions later, because you disrupt their facet complex and so on, and they develop iatrogenic instability. However, the minimally invasive people, 5 to 10% of them will need an open decompression. So it's like a kind of a continuum. You go from minimally invasive to open to fusion. So if you start minimally invasive, the next thing that you're going to offer that patient is an open decompression. But if you start with open decompression, the next thing that you're going to have to offer the patient is a fusion. And so I think in that regards, I think that there's some advantages to the minimally invasive. And I tell all my patients, we're going to try this minimally invasive, and there is a risk that, you might need an open surgery. For my open surgeries, I tell them, there's going to be a risk of you needing a fusion, which is a much different operation than a decompression. Now, in terms of a grade 4 spondylolisthesis, I don't think that there's good ways minimally invasive to do this. Now, I didn't present it at this talk, but we've actually started to do minimally invasive robotic ALIFs. So using the Da Vinci robot to actually go into anteriorly to do the ALIF. We've just done a few cases, but the results are very promising. And so no longer does the patient even have an incision in their front. It's all kind of laparoscopic. So maybe next year I can present it to you guys.
Thank you.
Any other questions?
Okay, William, time to move to the next speaker.
So unfortunately, he is not going to be able to join due to unforeseen circumstances, but we hope to welcome in a future session. Thank you so much, Prof. Abdelbar, for your time, your insights. It was a wonderful session, and it was truly an honor to have you with us.
Oh, it's my great pleasure. And for all the medical students, the residents, and so on, keep working hard. You will make it.
Hopefully.
Okay, thank you very much.
Many thanks to Prof. Muhammad Abdelbarar for excellent presentation. And inspiring presentations.
Okay, Ahmed, do you want to say anything? Ahmed,
First of all, I would just to apologize for joining late, but I think both Bayam and Abdurrahman did great, and they are trust, and they are actually maybe better than me to present and to organize this webinar. So sorry again for being late, and thank you both Abdurrahman and Bayam for taking it. I mean.
Okay, very good. Now, the second speaker canceled, correct, Bayam?
Yeah.
Okay, thanks everyone for coming. We'll see you at the next webcast.
Take care.
Goodbye, everybody.
Bye.
Stop the recording.
جاهزين خلاص.
Okay, very good. It went well. That went well.
Alhamdulillah.
So the second got canceled, huh?
He stopped.
روح لبروف عاطف مالك يعني ايش اسمها ابو يعني بعتت عن المحاضرة
Yeah,
يعني ما
he couldn't join us. He excused himself.
You know, Abdel, Bayam demanded money. And I said,
Ooh.
we don't pay slaves.
I think I deserve to be paid, even if I'm a slave, just a tiny little bit.
I am slave. We don't pay slaves. Okay, everyone, thank you. I got another
Yeah.
I got another
Thank you,
webcast.
thank you, John. Thank you, John. You did great, and we are so appreciated for you. Without you, we can't do anything. So we are so appreciated for you for bringing, for organizing this and hosting this. So thank you again, and we are so appreciated for all your supports, either today and I mean the previous days. So we are so grateful. Thank you so much.
Okay, I didn't hear what you said. Can you text me, Ahmed?
I
Okay,
just thank
have a
you.
good-
Bye.
Have a good day.
You-
Thank you,
but-
people, everyone.